Professor of Gastroenterology Hepatology from Quetta, Professor Sharbat. So, sir, please take the chair. This session is about an area of hepatology, which is hepatitis B, always an area of debate. And since long we have been thinking when to treat, how to treat, with what to treat. And one of the questions which we have been asking ourselves is about chronic hepatitis B, which is E antigen negative, especially in patients who are non-cirrhotics. So it is good to know that even the experts of this field are perplexed at this same situation. Okay, so I think we need no introduction with Professor Paul Coe and Professor Maria Buti. Both of them, they are best in their fields. They have been working in viral hepatitis for long, and they are going to debate on this issue that hepatitis B E antigen negative disease we should treat for lifelong. Paul Coe is of opinion that it should be. So let's hear him.
Good afternoon. And again, thanks so much for the kind invitation to make the case for continuing therapies in hepatitis B antigen negative chronic hepatitis B. NUC therapy should be continued lifelong. Here are my disclosures. So we've already heard so many excellent talks about hepatitis B today, and so needless to say for this experienced audience, don't need to remind you of the magnitude of this disorder. 250 million people infected, 2 billion people exposed. And if you look worldwide, hepatitis B with C caused 96% of the deaths from viral hepatitis worldwide. And so particularly hepatitis B and cirrhosis leads to a large number of deaths. And we also know that hepatitis B causes approximately 40% of the world's cancers as well. And so for all of these reasons, we treat people for chronic hepatitis B. And this very helpful classification of hepatitis B, which came from the EASL guidance, shows that there are really two phases in the chronic hepatitis B natural history where we treat. One is with E antigen positive chronic hepatitis, and then the other is with E antigen negative chronic hepatitis, where we have elevated ALT, we have an HBV DNA level that's above 2,000 international units, and it's because of immune clearance of the hepatitis B here that there is disease progression risk, and we typically offer therapy at that time. And the therapies we offer have really evolved. Interferon is used quite rarely nowadays, and so nucleoside polymerase inhibitors dominate. And the reason that we want to initiate treatment is for a variety of endpoints. So we want to suppress the HBV DNA. We want to normalize ALT. We want to try to seroconvert if you're E antigen positive, and if you're E antigen negative, we want to lose surface antigen. And we obviously want to improve liver histology because all of these can improve our outcomes. And indeed, that's what happens when you start nucleoside-nucleotide analogs. Dr. Esteban earlier this afternoon pointed this out in great detail with a wonderful case that showed that fibrosis actually improves. And this was the larger publication by Patrick Marcellin, just showing that when you looked at the fibrosis distribution for chronic hepatitis B patients treated with tenofovir, that you had regression not only of advanced fibrosis, but that more and more subjects trended toward minimal fibrosis, ESHAC fibrosis score, stages 0 through 2. And again, 74% of patients with cirrhosis at baseline no longer had cirrhosis at year 5. And again, similar data have been presented for the other nucleoside-nucleotide analogs, particularly entecavir. And not only that, if you have advanced fibrosis, then antiviral therapy really does improve your outcomes by reducing the likelihood to progress to an advanced child Turcotte-Pugh score, develop decompensated liver disease or hepatocellular carcinoma. And this was a landmark paper, probably the best documented. It was published by Dr. Liao and colleagues in the New England Journal almost 20 years ago. And so when we look at those who are on nucleotide analog therapy, what you can see is that the risk of hepatocellular carcinoma falls, and it also falls when we normalize ALT on nucleotide analog therapy. So what you have here are cirrhosis, and let's go down here to non-cirrhosis at the bottom here, and you have an abnormal ALT versus a normal ALT, and you can see here that this the risk is substantially reduced, hazard ratio 0.48. If you normalize ALT on nucleoside or nuke therapy in the absence of cirrhosis. And this benefit also seems to be of reduced HCC seems to be in the first 5 years of therapy. After that, in those without cirrhosis, there doesn't seem to be much benefit. However, in those who have cirrhosis, there is still continued benefit. And then finally, this was a very interesting paper that was looked and compared in one of the tenofovir registration trials, long-term tenofovir, in 283 HB antigen negative subjects without cirrhosis. There were 8 cases of hepatocellular carcinoma, and they looked at these 8, and then they predicted, using the HBeAg model, the number of observed hepatocellular carcinoma or predicted hepatocellular carcinoma cases there would be, and there was a substantial reduction. Again, showing that long-term treatment with nucleoside analogs actually has benefit of reducing the rate and risk of hepatocellular carcinoma, in addition to reducing fibrosis. Now, the other thing is that despite all this efficacy, surface antigen loss is extremely low on treatment. And this is just a potpourri of different therapies we've had approved over the years, showing that in e-antigen negative patients that you have really quite low surface antigen loss rates over periods up to 5 years. So the question is then, if we have all these positive benefits, why would we stop treatment? Well, we would stop treatment, number one, because of cost. And, you know, in many parts of the world, these therapies are only reimbursed for a finite period of time. Patients get tired of it. As Dr. Esteban said earlier, a patient comes back and says, can I stop my treatment? I'm getting tired of taking this. And so the question is, if we do stop treatment, what are the potential benefits and what are the potential harms? So what you can see here is you stop, if you're on a nuke and you're doing well, and if you stop, there's multiple potential outcomes. So one potential outcome is the HBV and the ALT can rise, and in fact, you can have a severe flare. You can serorevert, and there are cases of decompensation and death that have been reported. On the other hand, you can also have you can have a flare but then resolve, but you can also then resolve to inactive disease. The surface antigen level can decline off therapy, and you can, with close monitoring, remain off therapy, treating, of course, if you get a clinically significant flare. So what do our current guidances say? Well, they say right now that for e-antigen negative, EASL says that in selected patients with greater than 3 years of virological suppression, if you can guarantee close monitoring for at least 1 year, that you could certainly consider stopping clearance. The AASLD says really it's just surface antigen clearance, and that maybe in select cases you can discuss the risks and benefits, but you should be referred to a center of excellence. And APOSL says that you can actually stop with surface antigen clearance and seroconversion of anti-HBs, and then those who have been treated for at least 2 years with undetectable HBV on at least 3 separate occasions, 6 months apart, are also candidates. And then for cirrhosis, in Asia, they recommend that you can consider EASL and AASLD say no to stopping in HB antigen negative cirrhosis patients. So what happens when you stop? So we talked about this study some. This is, again, from the European group here, and this was discontinuation protocolized in those taking entecavir or tenofovir, and they stopped the NUC therapy, and you can see here over a year that you had a cumulative surface antigen loss of about 20% in this cohort, and you had surface antigen levels that were less than 1,000 in up to two-thirds of the individuals, with surface antigen level being predictive of ultimately clearing surface antigen in these patients who had stopped their NUC therapy. So that was actually not too bad. So then another study, which was recently reported, also looked at protocolized surface antigen loss in chronic hepatitis B patients. And these individuals in this presentation last year from the AASLD, they looked in patients 945 who stopped therapy after 4 years and followed these individuals. They defined sustained remission as a persistent HBV DNA less than 2,000 international units and ALT less than 1.5 times the upper limit of normal. And this seems to be one of the evolving standard for treatment success. And they also looked at surface antigen loss. What did they find? Well, they found that 1/3 of the patients, about 30%, could achieve sustained remission. And then 20% had sustained remission in the absence of surface antigen loss. 10% over 4 years had surface antigen loss, and 35% had to initiate retreatment. So whether or not that's really success, that's debatable. In the paper that was subsequently printed that just came out in Gastroenterology, what they looked at in a slightly larger experience was a surface antigen rate clearance after stopping therapy of 13% over 4 years. And what they stratified for was that if you're Caucasian and have a surface antigen level less than 1,000, then 41% chance of clearance. If you're Asian, the surface antigen level needs to be less than 100, and then you have about a 33% chance. But overall, the number of individuals, and again in this cohort, there were 1,546 who stopped therapy. Just 114 cleared hepatitis B surface antigen over a 4-year follow-up period. And again, this was a similar experience, was with even more discouraging results, was reported from the Canadian group here. This was published a few years ago in Gut. And again, here we had E antigen negative with DNA negative for at least 3 years, with surface E antigen loss also greater than 1 year. And they were randomized 2-to-1 to stop versus continuing nucleoside analog therapy. And what you can see here is that the surface antigen loss rate in this Asian population was extremely low. There were also relapse or retreatment required in over half, and only 30% with sustained off-treatment response. And so this doesn't seem in exclusively Asian patients to be a particularly effective therapy as well. Again, which is why we should continue our surface antigen. We should continue therapy in our E antigen negative individuals. This is a recent review paper that looked at surface antigen loss over a variety of trials, but again, I would just say they're quite heterogeneous. But all of the surface antigen loss rates are relatively low, ranging anywhere from 0 up to 33%, depending on the population being studied. This was another very nice study that looked at surface antigen clearance after cessation of nucleotide analog therapy. And again, these were Asians, 691, and stopped NUC therapy by our apostle stopping rules. And again, I've already alluded to this, but a 6-year cumulative surface antigen loss was 13%, or about just under 2% per year. If you have a surface antigen reduction during therapy of greater than a log or a low surface antigen level, you seem to be more likely to clear. But the incidence of surface antigen clearance after stopping NUC was much higher than during therapy. And again, here we have the results showing that if your surface antigen level is low, which is shown here, less than 100, that you had a reasonable opportunity to clear surface antigen. And also, if you had a clinical relapse, that is, you had DNA rebound, your ALT went up, but you did not get treated, your opportunity for surface antigen loss was also in the highest category. Finally, this study, which was presented a year ago at the liver meeting, looked at protocolized withdrawal with the addition of interferon, because one of the questions has always been, if you add an immune modulator, are you going to be able to improve surface antigen loss? And in this study that was very well done, they randomized 98 hepatitis B e antigen negative subjects in this study to either tenofovir or peginterferon plus tenofovir for a total of 192-week duration, of which the interferon was given for 24 weeks and then withdrawn. And what they found was, in the tenofovir arm, only 1 out of 98 had surface antigen loss, and those eligible for withdrawal. And so again, a disappointing response. Again, about a third developed inactive hepatitis B. And of course, the real concern is that you can develop a severe hepatitis flare. And this was a study that was presented recently that showed that in a study of over 10,000 treatment-naive adults who initiated entecavir and entecavir and stopped treatment, that flares occurred in about 6.5% of individuals. And while not common, there is a mortality associated with the subsequent hepatitis flares that we have to be careful of. And so for all of these reasons, I think we should definitely continue hepatitis B NUC therapy long term. And the benefits are many. So you reduce inflammation and hepatocellular injury. You reduce over time fibrosis. And again, the normalization of ALT is probably the most immediate benefit, but over time, fibrosis, cirrhosis gets better. Unfortunately, the suppression of cccDNA or integrant DNA is something that is not particularly affected by the nucleoside-nucleotide analogs. And so this is why we continue NUC therapy indefinitely or until surface antigen is lost. So the goal, why we should continue NUC therapy in those who are e antigen negative hepatitis B until surface antigen clears, the reasons are many. The goal of therapy for chronic hepatitis B is functional cure, that's surface antigen loss, and all of the benefits associated with this. Nucleoside analogs, they're safe, and the benefits have been proven, as we've discussed. Reduce fibrosis, reduce decompensation episodes, reduce hepatocellular carcinoma risk, and the protocols, even the ones with the most promising results, evaluating protocolized nucleoside withdrawal, they've all shown low rates of hepatitis B surface antigen loss. Finally, hepatitis B flares are real, and if you've ever taken care of one, they can be quite anxiety provoking. You have to monitor these patients closely, and it has led to mortality. If you do want to do this, you have to be sure that you're monitoring your patients. And then finally, even if we get to a sustained response after withdrawal, and that has been defined in the literature as an ALT less than 1.5 times the upper limit of normal, with an HBV DNA less than 2,000, is that really better than full suppression with our NUCs and normalization of ALT? I submit to you that if I am an individual with hepatitis B who has chronic condition, I would prefer to have no virus in my bloodstream rather than to have a low level of virus with a medicine that is very well tolerated. I'm going to stop here, but I hope I have convinced you and made the argument that at least for now, till we get better therapies, NUC therapy is best continued in this e antigen negative population. Thank you.
Thank you, Professor Naham. Good afternoon again. I think Paul has shown clearly the benefits of continuous treatment, but not all HBe antigen negative patients need to continue NUCS lifelong. And I would like to share with you some potential indications of NUCS discontinuations particularly before HBs antigen loss, because I am sure that all of you agree that after HBs antigen loss, we can stop NUCS. But let's see what happens before HBs antigen loss in an E-negative patients without liver cirrhosis. Probably I am invited here to support NOTE because I was part of the panel of EASL guidelines. And the EASL guidelines say stopping therapy may be considered for a selected patients E-negative without liver cirrhosis. And it's in the same line to PASL guidelines and completely different from American guidelines that supports indefinite treatment. Paul has showed this slide, and in E-negative patients, the goal of stopping treatment is to achieve HBs antigen loss. Achieve HBs antigen loss in a higher proportion than those observed in patients under NUC treatment. And the second goal, if this is not achieved, is to achieve sustained virological response, such as a healthy inactive carrier. So this is the goals for stopping treatment. And why this? And Paul has summarized very, very well that HBs antigen loss increase survival. So this is a strong endpoint. The state of inactive carrier, it's an intermediate endpoint. A benefit of stopping treatment is that some patients can continue without treatment, and clearly we reduce cost. But there are some cons, and the cons has been clearly shown: HBV DNA rebound, ALT flares that can lead to hepatic decompensation, an active retreatment plan, and we need a careful selection of patients. So for this careful selection of patients for stopping treatment, we need some predictors. We need predictors for HBs antigen loss and predictors for the bad side effects for HBV DNA rebound, and particularly for ALT flares. Let's look if there is any predictor for HBs antigen loss that happens after stopping treatment between 4 and 24% of patients. That is much higher than this 1% shown previously by Paul in patients under treatment. So what is the best predictor? This is one of the studies. It's a randomized study performed in Germany. And in this study, patients were randomized to stop NUCs or continuous NUP in negative patients. And the arm that stop NUCs, HBs antigen loss was 10% after 96 weeks. And what is important in this study is that the factor that predicts or is associated with HBs antigen loss are the levels of HBs antigen. Those below 1,000, the possibility, the likelihood is 28%, when those higher than 1,000 is very, very low. Please remind that this study was performed in Germany in Caucasian patients. And this is not the same in Asian studies. In Asian studies, the cutoff is much lower. It's 100% associated with HBs antigen loss in between 21-59% of cases, and those with higher levels, the rate of HBs antigen loss is very, very low. So we have a predictor that is HBs antigen levels different for Asian people and European people, and clearly this can help to select patients that stopping treatment can achieve HBs antigen loss, that it's an important endpoint associated with a greater survival. So more data about HBs antigen loss is this study, multicenter European study performed by the group of Harry Janssen, now back in Europe. And in this large study, the predictors of HBs antigen loss again were the levels of HBs antigen less than 100, and undetectable correlated antigen and HBV genotype C, and non-Asia ethnicity. So if you can do HBs antigen levels, then you can stop in those with low levels. If you cannot do HBs antigen levels, my recommendation, only try to stop in some Caucasian patients, not in Asian patients. So then we need to have predictors, particularly predictors of ALT flares, of HBV DNA rebound and ALT flares. Predictors of HBV DNA rebound, there is no predictors. The majority of patients, almost all, after stopping treatment have HBV DNA rebound. But this HBV DNA rebound is transient in the majority of cases and is associated with clinical relapse, that means ALT flare between 20 and 50% of cases, and these cases need retreatment. What are the predictors of ALT relapse and clinical relapse? One is the HBV DNA levels when we stop treatment. If you stop treatment and there is an important increase in HBV DNA levels, please put again the treatment. Don't continue discontinuing treatment. If the levels are very, very low and remains low, this could be a good option for stopping treatment. And then we have these new biomarkers that are not available for everybody, that some of them are not very well standardized or even non-commercial available, but can give some light on the possibility of stopping treatment for some patients. And it's very easy. So there is association between suppression of these biomarkers and no rebound. So that means that patients that achieve HBV RNA levels undetectable are those with less rebound and less viral and clinical rebound. The same is true for correlated antigen levels. Those who achieve undetectable levels and even associated with HBV RNA are those who are not going to have ALT flares, no flares. And this is also a study recently presented, a multicenter study that clearly showed that the combination of low levels of HBs antigen and undetectable HBV RNA and low levels of correlated antigen are associated with sustained virological response associated to inactive carriers. So that means that low levels of HBs antigen and low replication, it's associated with less or predict sustained virological response. And this is an algorithm suggesting that the combination of these biomarkers can help to identify patients with very, very low risk of HBV reactivation. What is the drawback of this? The main limitation is that these biomarkers are not available for everybody. So what is available for everybody are ALT. So what happens when there is an ALT flare? And I think what is important is to differentiate between a beneficial flare or a risky flare. And the beneficial flare usually is preceded with a rebound in HBV DNA, and when ALT flare appears, then we can see a rebound in HBV DNA. But if there is a risky flare, there is no decline in HBV DNA levels. There is an increase in ALT levels, and HBV DNA levels remains high. Then this is not a good flare. It's a risky flare, and it's clearly an indication of rapid instauration of retreatment. So another factor important are the type of drugs. Patients under tenofovir have more virological relapse and early virological relapse than those receiving entecavir. And biochemical relapse occur early with TDF than with entecavir. So patients with TDF have a higher likelihood of having early virological and biochemical relapse. So stopping NUCS in E-negative patients means always be prepared to early retreatment in case of clinical relapse. And we know that early retreatment also reduces the chance for HBs antigen loss. So it's difficult to take the decision. So my recommendation is to have a criteria for early retreatment, and this criteria should be based on HBV DNA increase, HBV DNA determination. So we don't need to wait for ALT elevation to restart treatment. So in summary, in HBe antigen negative non-cirrhotics, NUC therapy should not be continued lifelong if you have the right candidate. And the right candidate is a patient with very, very low levels of HBs antigen, but also you need that you as a physician and the patient are ready for a more intensive monitoring. The patient has to be excellent in terms of adherence. The physician has to be an expert on management of hepatitis B, and particularly in retreatment. So we need a careful selection of the patient, particularly good guys. Thank you very much.
Thank you so much, Professor Maria. She suggested to the patient that, look, you can stop the treatment, but you have to test yourself extensively and frequently. Our patient is a Pakistani patient. He doesn't want to stop the treatment. He doesn't want to take the treatment for lifelong, and he doesn't want to test also. So what is the conclusion? Let's look at the chairpersons for their concluding remarks for the session.
Which we do not have a definitive treatment. So to continue them lifelong with less monitoring, or to stop and continue vigorous monitoring, that's a decision in which still we need more evidence, more treatment options to become available, and hope with coming in future times we'll have some answer to this. So till this, what I recommend that my opinion will be to follow these individualized pattern and a physician discretion involvement with consultation with the patient, and taking the patient into the confidence is very important in this case. Over to you, sir.
It's not an easy answer. There are a number of facets to the case. We've got gastroenterologists, hepatologists in the audience with over 3 decades of experience in Pakistan. The one way of going out about it is to have just a show of hands. You say how many would go
Yeah.
in favor of continuing their patients on treatment in
Of-
this scenario for as a lifelong, and how many would say we would stop.
Those who will stop the treatment.
So can we have a show of hands? Yes, they would continue lifelong.
Most of us. It is easy. Actually,
And how many would not continue lifelong and stop?
वैसे साइंस में जमहूरियत नहीं है.
only few.
So
I think the case pleaded by Dr. Paul is very convincing according to the show of hands. But I fully agree with Dr. Maria as well that that in some patients, if they are compliant and if we can carefully select the patients, then it may be worthwhile to stop the treatment. But this topic is going to be it is going to generate a lot of debate, and it will test the acumen of the treating physician as well, how carefully he follows and sees the patient. But according to the show of hands, Dr. Paul I think he has convinced the audience.
A good presentation by both the speakers. I think that in our society, discontinuation will be very harmful because the patient not follow the the guidelines for close monitoring. Initial viral load is very important. If the initial viral load is very high, then we should continue the treatment lifelong. If the initial viral load is low and HBeAg loss occurs and the initial response to the therapy is very good, then we should discontinue and advise the patient to closely monitor his ALT and HBV level. If they don't follow the guidelines, so we should continue the therapy lifelong. Thank you.
Thank you very much. I think partly Professor Maria also agreed, because she said that if you are an Asian, then carefully select those who you are going to stop the treatment. So most of us will continue the treatment lifelong. If there are no questions, I don't see any questions. So we will move on to the last session of today's meeting, inshallah, and that would be SCV elimination by Dr. Asad Chaudhary.
That's what